Hello and welcome to PulseCheck with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling something called Neonatal Abstinence Syndrome, or you'll probably see it abbreviated NAS. So as always, let's kick things off with our practice question. A nurse is caring for a newborn with suspected neonatal abstinence syndrome. Which nursing action is the priority? We have A, swaddle the newborn and reduce noise and light in the room. B, offer large, less frequent formula feeds to promote weight gain. C, place the newborn under bright lights for continuous observation. Or D, limit parental contact to prevent overstimulation. Okay, as always, we're going to circle back to what the right answer actually is and why at the end of the episode. Try to think of what you maybe think is the right answer, tuck it away, and let's dive into what is going on in neonatal abstinence syndrome. This is something that we see in babies. So to understand, we really need to get into the A and P happening even before baby is born. So during pregnancy, anything lipid soluble and small enough is able to pass through the placenta. Remember, that's like our lifeline. We got a lot of blood supply going from mom to placenta to baby. Now, one thing that is really small and lipid soluble and good at passing through the placenta are opioids. So if a pregnant person is using opioids, that could be heroin, fentanyl, oxy, methadone. Any of those drugs are crossing the placenta and entering fetal circulation, and baby is getting a good, steady supply of that to their system. Inside the fetal brain and nervous system, opioids are then binding to their opioid receptors. Those, we call them a mu-opioid receptor, and you can think of that as like a little chill out button. They are going to calm the central nervous system, slow down the GI tract. Basically, you can think when an opioid binds to that mu-opioid receptor, things are getting slowed down. Pain signals are dampened, the GI tract moves more sluggishly, and our autonomic nervous system is like a little more sedated. So if they are exposed to these over weeks and months, they adapt and are used to that constant opioid pressure. The brain is then down-regulating its own endogenous opioids and adjusting the sensitivity of those receptors so that their normal is having those opioids on board. They get used to it. Now, introduce birth, we cut the umbilical cord, and all of a sudden, that supply of opioids is gone. The baby's liver and kidneys start clearing out the drug, but their nervous system is still used to having it. So you have a new little baby brain and body who are expecting to get opioid input and they're not getting it. Basically, they go into withdrawal. Those receptors that were constantly stimulated are now empty. The nervous system rebounds. Here's a little analogy that'll maybe help as we get into our symptoms. If the opioid during pregnancy is like someone holding down the down volume button on our autonomic nervous system, they're like putting it on mute, keeping things quiet. Then birth and cutting that umbilical cord is like suddenly we let go of that button and the volume slams up to the max. Our sympathetic nervous system really goes into overdrive. So symptoms, we are seeing jittery, tachycardic, tachypneic, crying, inconsolable. Their nervous systems are firing all over the place, okay? They were dialed down. We take away those opioids that were dialing them down, and they rebound back up. Same thing going on in the GI tract. Remember, things were slowing down? So we had like lower heart rate. We were like really chill. Now we're tachycardic and really jittery and really, all over the place. Remember, the GI tract was really slow gut motility. Those fetal intestines have been living in slow motion. We remove the opioids, motility rebounds. Now the gut is hyperactive, so we get poor feeding, frantic sucking on their thumbs, pacifier, whatever, very uncoordinated swallow. They're swallowing all this air, having regurgitation. They have super loose, watery stools that can then funnel into a horrible diaper rash I'll talk about in my story today. And it can contribute to weight loss because their gut is just a moving. It was slowed down in utero with those opioids. It has rebounded. It is going way too fast. This also disturbs how they're regulating pretty basic functions like the sleep wake cycle, which we know babies are not great at overall anyway. But the sleep wake cycles are totally disrupted because of that overstimulation we've been talking about. So their muscle tone increases. They're really what we call hypertonic, tremory, rigid. They really have a hard time relaxing those muscles. The autonomic system is firing off little storms where they sweat and they sneeze and they yawn. They're really stuffy. Their temperature is labile. Like their system is so in overdrive that it can't regulate basic functions. And the worst case, if the withdrawal is severe enough, is that they have so little regulation that electrical irritability in the brain can increase their risk for seizures. Now, you might think that this happens like immediately after birth. We cut that umbilical cord, baby's supply of opioids are gone. Now, sometimes that, more or less is the case if we have a really short acting opioid on board, like heroin. That is out of the baby's system rather quickly in about 24 hours. So we'll see it about in that first day after birth. But more commonly, we see longer acting meds like methadone, for example, where we might not get peak withdrawal until even 2 or 3 days after birth. So you need to know that as the nurse, because if mom was on methadone during pregnancy, you don't want to discharge her at 24 hours, send her home with baby like, hey, they looked really, really good. We're going to need to observe for several days just to make sure that baby really is doing okay, because they had that longer acting med. They're still kind of clearing that out of their system before they go through withdrawal. So I have been able to work with a lot of babies with neonatal abstinence syndrome in the days that I worked in the NICU. I will say actually some hospitals now have their own NAS unit because it is unfortunately not uncommon, and they'll put all of those babies in the same area because they require similar types of care, which we'll talk about here. But I'm going to tell you the story of one baby in particular that jumps out to me. It was a baby boy. I'm going to call him Liam just to have a name. That wasn't actually his name. But Liam was born full term, like 39 and 3, normal spontaneous vaginal delivery, great APGARs. His newborn assessment was largely normal. But his mom had been on methadone throughout pregnancy. So we knew this coming in. Mom told us this. We had a plan ready to go. We knew Liam was likely going to have some degree of withdrawal as that methadone cleared his system. So we were watching him for this. We were ready for it. In that first day postpartum, honestly, baby boy was good. He had a really good feed in L&D, which is quite typical. And then he was pretty sleepy for the first day. Second day, he started to wake up a little more. And that was when I would say at that like maybe 36-hour mark, we started to see some of those signs of withdrawal. So some of the things I saw in my first assessment on that day too. He was very difficult to calm down. His arms and legs were really constantly moving, and they had little tremors. He was very, very stiff, hard to get him to like relax. And, not in like a, oh, chill out type of way. Like, really, I'm really talking about his muscles. Like, his muscles were tight, hypertonic. Now let's talk about his cry. All right. These babies have a different cry. It is honestly kind of hard to explain. The textbook thing we say is like it's high pitched. And it is. It's almost kind of like a sharper, maybe like a siren. It's not that softer newborn wail. And it's very hard to console these babies. They are crying, crying, crying in that much higher pitched tone. So I'm starting to see all of these things set in around that day and a half mark. Let's talk vital signs now. They really all looked fine day one. Respiratory rate started trending up day two, which makes sense with how much his crying and irritability, right? He's breathing faster. 70s isn't the end of the world for a baby like it would be for an adult, but it's higher than I would like it to be. I will say importantly, his lungs were absolutely clear. His O2 sat is normal. While he was quite tachycardic in the 180s because of that active crying, he still had a normal heart rate and rhythm. And when we did briefly have him up on the monitor, everything looked fine. So, really, based on vitals, I'm just seeing, he's breathing fast, his heart is beating fast, he's crying, he's upset, he's irritable. It is really hard to calm him down. So, these are all classic things that should make you think, okay, was this baby exposed to opioids in utero? We're hitting this day and a half mark. Are they withdrawing from a substance? And with this baby, with Liam, we knew that he was withdrawing from methadone. So right from the get-go, we started using a standardized scoring tool to score those symptoms of NAS. Now, different hospitals are going to use different tools, but it is really important to be using the same tool with the same set of criteria that is standardized, because that lets us kind of track how they're responding to our treatment. Are they getting better? Are they getting worse? It basically takes all of those symptoms that we just talked about and adds them up. So are they irritable? Are they hypertonic? Do they have a tremor? Are they sneezing, yawning? Do they have that nasal stuffiness? Have they had loose, watery stools, etc., etc.? The more points they get, the higher that score, the worse off we are. We want to see nice, low scores. So what do we do when we have those higher scores? They're withdrawing. This is like physiologically, this makes total sense. He was used to methadone. Now he doesn't have it. His body is going through withdrawal. What do we do? First line, as always, let's start low and slow, non-pharmacologic. We are going to use environmental and comfort strategies that kind of match what the nervous system needs. We got to quiet this baby down. We got to move him to a nice little nook that is not too loud. We want to dim the lights, shut the door, keep our conversation soft and calm. Just think what you would want if your nervous system was all revved up. We want less stimulus, less light, less voices, less touch, etc. Next thing I'm going to do is I'm going to swaddle that baby up like a burrito. I'm going to swaddle him so good. We're going to tuck in those arms, tuck in those legs, really trying to give him a safe sense of boundaries. I always think of the swaddle as trying to mimic the womb. He was just born a day ago. Up until a day ago, he was really tightly nestled in there in mama's uterus. And now he's just out here, all this stimulus. He doesn't have his methadone anymore. So we need to bring it back to the womb and remind him of those safe boundaries. So swaddling is, it's kind of like a hug. We're putting him back where he's used to it. That also helps a lot with the tremors, because if he's just, jittery, tremory, hypertonic all out here, they can kind of work themselves into a tizzy, versus if they have those boundaries, it kind of gives them some feedback and can help calm. So swaddle that baby up really, really good. And then use slow rhythmic rocking to help kind of shush him down. We don't want jostling, loud, lots of input chaos. Next, let's talk about feeding. We want to do some small, frequent feeds rather than large volumes. Remember that GI tract, it had really slowed down in utero with all that methadone. So we don't want to overdo it. We want to do small, frequent feedings, not overwhelm that GI tract, and we want to watch out for those loose stools that can definitely cause some diaper rash. That usually takes a little longer to set in than just the first day. Hopefully they're just going to pass their meconium on the first day. But after 2-3 days or so, they can get some pretty bad loose stools. As you feed them, you're also going to want to be very careful to kind of pace them. Again, we're trying to think slow, steady, and calm. They are at high risk for aspiration and vomiting because they tend to be really kind of frantic and uncoordinated. That that suck, swallow, breathe reflex is very hard for them with how overstimulated their nervous system is. So, do all those things that you would to slow them down. Do the things you would do for a baby with GERD, where you keep them up right after feeds and really try to reduce the risk of, vomiting, reflux, and, both those can lead to aspiration, and that's a whole nother problem. So that is how we want to do about feeding. And then I mentioned a couple of times about the loose stools and how we need to do really good at skin and diaper care because of them. By that, I mean a thick barrier cream, changing him as soon as there is a wet or dirty diaper, and making sure you let that bottom air dry between changes as feasible, so that we can really keep that skin barrier intact and, prevent breakdown as much as possible. But I will say some of these babies are having a loose stool, like, oh my gosh, it seems like every hour. So it can be really, really hard to keep up with. And it's just something you're going to have to keep your eye on. Okay, so those are kind of the non-farm things. We are going to be doing that at baseline for any of our babies who are dealing with NAS. Now, I did mention earlier we are doing that scoring so we can track how their symptoms are going over time. And higher numbers, they are in overdrive. We're looking for lower numbers to be a good score. As those numbers are higher, we need to start thinking about some pharmacologic measures as well. And I bet you guys can have an educated guess as to what I'm going to say here, because all of this dysregulation is happening as we have withdrawn opioids from the baby. We are going to introduce opioids back in a small, safe dose that we can titrate down slowly as the nervous system calms down. Remember, if we are really out of control, this baby is at risk for seizures. So going cold turkey on something like heroin or morphine is not a good idea. If we know that has happened, we need to reintroduce low-dose morphine or methadone. I have typically seen methadone with breakthrough PRN doses of morphine when the baby is really struggling. And we start it at a certain dose and we taper it down slowly so that we can kind of wean that nervous system off of it and help that nervous system cool down. I know, it kind of sounds counterintuitive at first. We're giving opioid to a baby going through opioid withdrawal. But think about the patho. We're giving a controlled, tiny amount of what those mu receptors are craving and gradually weaning them off so the brain can reset instead of just crashing down into that full-blown withdrawal that is super, super dangerous. Now, how long is the baby going to be in the NICU? It is totally dependent on what they were exposed to prenatally, how long they were exposed to it, what the dose of it was. It's somewhat of a trial and error to gradually wean those medications down and get the baby to a point where they can go home safely without them. Some babies progress quite quickly. They're only there for perhaps a week or so. And for some babies, it is a much longer stay because we really need to take it nice and slow. Sometimes they can regress a little bit, need a couple breakthrough doses of morphine, and then we need to go back up on that methadone. We really have to follow the baby's cues and take them nice and gently through that process. Remember, all the while implementing those non-farm actions, a swaddle, a dim, quiet environment, nice, steady rocking, etc., etc. That is going to be your care for a baby with NAS. So with all that being said, I think now you are ready to go back to your practice question. I bet you will absolutely get to the right answer. Here we have a nurse caring for a newborn with suspected NAS. What is the nursing priority? So we had A, swaddle the newborn and reduce noise and light. B, offer large, less frequent formula feeds to promote weight gain. C, place the newborn under bright lights for continuous observation. Or D, limit parental contact to prevent overstimulation. What is the priority action for our baby with NAS? All right. Did you say A? I bet you did. I know you guys have got it. Swaddle, low stim environment. That is absolutely the bread and butter of care for NAS. We are trying to lower that stimulation so that we can promote calming and let that nervous system rebalance. B, C, and D all had certain things that we do want to do, but not the right way. So in B, yeah, we want to promote weight gain, but not with large, less frequent formula feeds. We want to do small, frequent feeds to be gentle on that gut that had really been slowed down with the opioid exposure in utero. For C, it's true we want good observation of the baby, but putting them under bright light is going to be overstimulating and not help us calm that nervous system down. And for D, again, we do want to prevent overstimulation, but reducing parental contact is absolutely not the way to go. In fact, we want parents involved. We want to teach them how to swaddle, how to soothe, how to feed their baby, because they're going to be doing this. The more involved they are, the better, and the quicker they're going to be able to take that baby home. So we don't need to limit their contact. We just need to make sure it's done appropriately. So honestly, you guys, key takeaway here is the effects of NAS are just a rebound from that in utero exposure to opioid. Baby got used to it. They're holding down the volume button. We let go and it rebounded. Everything goes up from the heart rate to the respirs, to the fast moving gut, all the tremors and hypertonicity. Everything just goes into overdrive. So your job at the nurse is to slow it down. Low stimulation, swaddling, small frequent feeds, protect their little skin, and empowering parents to really be a part of that plan. Medication-wise, when we have that moderate to severe withdrawal, we're going to taper them down and really slowly help that nervous system regulate. NAS is all about nervous system regulation. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to PulseCheck with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.